Welcome to Lecture 8 in the series Introduction to Cardiology. In this series, we are going to consider one of the most serious problems that faces a cardiologist, the patient with heart failure. Heart failure is very common and increasingly common these days. It's because it is a common complication of older individuals, and of course, the older population is increasing throughout North America and Western Europe, as well as Asia. Heart failure is defined differently in different circumstances by different cardiologists, but basically it's an inability of the heart to pump enough blood to meet the demands of the body. In other words, if one exercises, one requires an increase in blood flow to the body, and if you can't do that, you may develop the symptoms of heart failure. As we're going to see, there are a number of compensatory mechanisms that get set off in heart failure, and some of them actually work to increase symptoms in these patients. The major issue here is that the heart has an inadequate or decreased cardiac output. Remember, cardiac output, that's stroke volume times heart rate. That is the amount of blood the heart puts out each beat times the heart rate. And in this setting, what you see is that the patient has an increase in blood volume because of compensatory mechanisms that work to correct the heart failure state. Unfortunately, this leads to fluid accumulation in the body and even edema, that is swelling in the body. This can also be associated with circulatory congestion, for example, in the lungs. So you have increased fluid in the lungs, so the patients are short of breath. And in addition, you may see patients being markedly fatigued because they're not getting adequate heart pumping. As I said before, it's a very common problem. There are more than 3 million patients in the United States with heart failure. There's a number of new patients presenting every year. And unfortunately, heart failure has a very poor prognosis, often a prognosis just as bad as many forms of cancer. Heart failure is more common in African Americans, and it's interesting that these patients seem to do better briefly when they're admitted to the hospital, but their long-term outlook is worse. Some of this may be because of lower socioeconomic conditions in many African Americans. The heart failure frequency in the U.S. has been increasing with an increasing population. A statistic I like to quote is that in the United States, in every 24-hour period, more people will become age 85 than will be born. So you can imagine if heart failure is a very common problem in the elderly, just as atrial fibrillation is a common problem in the elderly, both of these are what I call, quote, growth industries. And again, women tend to be a little less frequently affected by heart failure. Men is a little more common early on, but once we get into the geriatric population above 65 to 70, the amount is about the same. There are a number of factors that are referred to when we talk about heart failure, and you'll remember some of these factors from the basic lectures on heart function. Remember preload. Preload is filling of the heart, so that it's a manifestation of the size of the ventricle when it fills up. When you have increased blood volume, you increase the preload, that is, the amount of volume that the heart has to squeeze out. This happens with some of the compensatory mechanisms that increase the blood volume, and consequently, preload may be increased in the heart, and what increased preload leads to is increased filling pressures in the ventricle during diastole, during the rest period. This leads to increased pressures in the ventricle during diastole, and those increased pressures are transmitted back to the lungs and even back to the rest of the body, leading to fluid accumulation in the tissues of the lung and the rest of the body. Afterload is the work of the heart. It's the resistance the ventricle feels when it is pumping out. This is usually due to resistance in the vascular system. You'll remember that from the basic lecture in cardiology. Increased peripheral vascular resistance leads to increased afterload, increased work of the heart. You can imagine that's not good in heart failure. And in fact, Here's a clue. When we talk about therapy of heart failure, one of the things is to decrease afterload, to decrease the work of the ventricle and hope that it will recover from its depressed state. There are two forms of heart failure, systolic and diastolic. In other words, sometimes, let's take diastolic first, the ventricle squeezes all right, but it fails to relax normally. It relaxes slowly or in a stiffened manner, leading to increased pressure in there that gets transmitted throughout the circulation and leads to collection of fluid, as we talked about before, edema. Systolic heart failure is when the ventricle fails to squeeze well. That can happen, of course, with the patient who's had heart attacks, happens to patients with cardiomyopathy, heart muscle disease, and often systolic heart failure is associated also with diastolic. So most patients with heart failure have both systolic and diastolic, but there is a whole group of patients, a minority as you can see from the circle diagram here, who have pure diastolic heart failure. Interestingly, the long-term prognosis for diastolic heart failure is just as bad as for systolic heart failure. Diastolic heart failure tends to occur in older individuals, often with thickened heart muscle. Now, there are a number of compensatory mechanisms that the body sets off when it sees heart failure. Remember, I mentioned them just a few moments ago. What are the compensatory mechanisms? Well, let's think. Why would the body compensate for decreased cardiac output, for decreased pumping of the blood? The reason the body compensates is because it interprets heart failure as if there had been a hemorrhage, a blood loss, or dehydration. In other words, the reduced pumping ability, the body interprets as, oh, there's a lack of blood from a hemorrhage, or there's a lack of fluid in the circulation because of dehydration. And it sets off a whole bunch of compensatory mechanisms aimed at holding on to fluid, water, and salt. Unfortunately, this is exactly the opposite of what we would want, because in holding on to fluid, you actually create the setting where patients put some of that fluid into the tissues, both in the legs as edema or in the lung as pulmonary edema. So the activation of the neurohumeral system, that is central nervous system initiated activity to correct the heart failure situation, actually makes the situation worse. These systems work great if there's dehydration, you're caught in the desert without water. They work great if there's a hemorrhage, you've been cut somewhere, or you're bleeding from an ulcer in your stomach. But they work, unfortunately, in a negative manner in the patient with heart failure. Let's just talk for a moment about why these compensatory mechanisms work. They work because of something I mentioned before, Starling's law, the so-called rubber band law of the heart. The more you fill it, the more it contracts. So what the compensatory mechanisms are trying to do is to increase the filling of the heart so it will squeeze more. As I've said, unfortunately, that leads to elevated pressures that back up in the system and result in edema. But the rubber band law of the heart says that the force of contraction is related to how much you stretch the heart muscle cells, and this increases contractility. So you see why the body is trying to increase the pumping ability of the heart, and this works fine if it's a hemorrhage or dehydration, but it doesn't work well when the patient has heart failure. So remember, stroke volume is the number of cubic centimeters that the heart puts out with each time it squeezes, times heart rate, that's cardiac output. So when we have a reduction in stroke volume because the heart has been injured, sometimes you'll even see the heart rate go up because the central nervous system says, oh, cardiac output is falling. We have to increase the heart rate. We have to increase our ability to hold on to salt and water and increase the blood volume and use the Starling law to increase the contractility of the heart. Again, unfortunately, it's not the right setting for that, and this leads to overfilling of the circulation, increased pressures in the circulation, and increased fluid getting out into the lungs and into the tissues. So the central factor in heart failure, of course, is depression of the heart muscle at least for systolic heart failure. But also in diastolic heart failure, the heart is supposed to actively relax, and there's also depression of that. But the commonest form of heart failure, as you've seen in the previous slide, was systolic, and it is usually because there's been some injury to the heart muscle, most commonly from ischemic or coronary artery disease with heart attacks. And again, we've talked about the compensatory mechanisms. Here are the compensatory mechanisms listed. First of all, they're initiated by the central nervous system. One of them is a signal that's sent to the kidneys and that the kidney actually does on its own. The kidney is the regulator of the blood pressure in the body. It sees a drop in blood pressure, a drop in cardiac output, and it releases compounds in something called the renin-angiotensin system, which holds on to salt and water. It's hormones that actively tell the kidney, hey, don't pee out sodium and water. Hold on to it because the circulatory system needs some volume. There are also hormones that are released from the pituitary, so-called antidiuretic hormone, which tells the kidney, hey, hold on to water. Don't let the water go out in the urine. In addition, you also will have activation of the sympathetic nervous system, which is part of the flight or fight system. This sends adrenaline to the heart muscle to try and get it to contract more vigorously, and it also clamps down a little bit on the periphery in an attempt to shrink the volume that the heart has to pump into. All of these compensatory mechanisms, you can see, they work great if we're talking about dehydration or hemorrhage, but they work in the wrong direction when the patient already has a depressed left ventricle. The other thing that happens is that the heart muscle remodels. It reconstructs itself, if you will. You can see in this diagram on the left, there's one form of remodeling, left ventricular hypertrophy, where the ventricle markedly thickens, for example, with aortic stenosis, as we talked about with the patient in the last lecture. On the other side is the sort of thing you see in a cardiomyopathy. The heart dilates, thickens a little bit, but predominantly what it does is it dilates. And you've all heard someone say, oh, so-and-so's in trouble. They have a, quote, big heart. That's because the heart's dilated. That's often the final stage of heart failure, when the heart has exhausted all of its other compensatory mechanisms to get the cardiac output up. Then you start to see this dilatation of the left ventricle. Now, again, we talked about the different kinds of heart failure, systolic and diastolic, but sometimes there are definitions based upon which ventricle is in the most trouble. Most common is left-sided heart failure. That's because the left ventricle has been injured. But in some conditions, such as severe lung disease with high pressures in the lung, you may just see isolated right-sided heart failure. So let's think about this for a moment. With left-sided heart failure, the backup is going to be into the lungs. Patients get fluid in the lungs and they're short of breath. So the edema is in the lungs with left-sided heart failure. With right-sided heart failure, the backup is into the veins, so you often see patients with fluid in the abdomen, fluid in the legs, so-called peripheral edema. And the left ventricle may be working just fine, but it's not getting any blood from the right ventricle because the right ventricle is failing. And of course, it's obvious what the left ventricle puts out depends on what the right ventricle puts out. They have to balance out. If they don't balance out, all the blood is going to end up on one side of the circulation or the other. And then we've talked about before, systolic heart failure, failure of contraction, diastolic heart failure, failure of relaxation. Here's just a little diagram to remind you how the whole body is a coordinated system. You see the brain is connected to the heart, the brain is connected to the kidneys, they're all connected to the peripheral blood vessels. And as we've talked about, when there's heart failure or when there's dehydration or when there's hemorrhage, all of these factors become activated in an attempt to A, restore the blood volume, and B, restore the pumping ability of the heart. And here they are, all listed again, just as we've talked about before. The central nervous system is critical. The sympathetic nervous system is activated. The kidney, through the renin-angiotensin system, is activated. And the ventricle gets increased volume and therefore uses the Straling mechanism. All of these things work together. They work great if the patient's blood volume is down because of dehydration and hemorrhage. They work against you when the problem is that the heart is not pumping enough. And again, here you see a diagram that just shows you how all of these interact, how the decreased cardiac output can lead to lung congestion, and how increased peripheral pressure can lead to peripheral edema, the neurohormonal activations through the kidney that go on. All of these things are working in a complete circus motion, like the horse riding around the track in a circus. Around and around, they keep reinforcing each other, and unfortunately, in heart failure, lead to marked retention of water and salt that leads to the various symptoms that the heart failure patient has. The American Heart Association guidelines talk about various levels of heart failure. Level A is somebody who's really predisposed to heart failure but has not developed it yet. So that's somebody with high blood pressure, diabetes, hypercholesterolemia, hyperlipidemia, as we've talked about, that leads to atherosclerosis. Heart failure hasn't developed yet, but the substrate, if you will, is ready to go on and cause a heart condition that will lead to heart failure. Grade B is when you're starting to have some very early signs of heart failure by some of our fancy tests, such as from the echocardiogram, but the patient is still asymptomatic. Stage C is when the patient is already having symptoms. They're tired, they're short of breath, they have peripheral edema, and stage D is when they're really incapacitated with heart failure, marked severe symptoms of heart failure. Now, it's important to remember that heart failure relates to atherosclerosis in the majority of cases who present to the cardiologist with heart failure. No surprise. Remember, we talked about the last time I spoke to you about the typical patient. That's the commonest patient that comes to the cardiologist, the patient with atherosclerotic heart disease. When that disease is advanced, particularly if the patient has had previous myocardial infarcts or heart attacks, the ventricular function is compromised and the patient shows up with heart failure. So what are the risk factors for heart failure? They're the risk factors for atherosclerotic heart disease. They're hypercholesterolemia, hypertension, cigarette smoking, diabetes, all the things we talked about before that can lead to atherosclerosis. And you can see that the commonest ones, are problems leading to heart failure is ischemic heart disease, but there's a number of other factors that are involved as well. But ischemic heart disease, the number one cause of death in the world, number one cause of heart failure. There are a number of rarer causes of heart failure. I'm not going to go into this in any detail, but for example, in the United States, one of the commonest causes of cardiomyopathy is excessive alcohol intake. Alcohol is a poison for the myocardium. Taken in small amounts, it's good, increases the HDL level, can be very pleasant in a social setting, but excessive alcohol can lead to cardiomyopathy and, of course, a lot of other problems, liver failure from cirrhosis, et cetera, et cetera. There are other things that can cause heart failure. We've talked about this before. Cardiomyopathy from a chronic viral infection. Certain drugs can do it. One of the favorite drugs for chemotherapy for breast cancer also damages the heart, and some other drugs can do the same thing. And of course, arrhythmias with long-standing fast heart rate that's uncontrolled can also lead to cardiac fatigue. These things are much rarer. Remember, ischemic heart disease is number one public enemy. And here you just see all of the symptoms that patients will have with heart failure. They will be dyspneic, that is, they'll be short of breath. You will find maybe their lips are blue because they're not pumping enough oxygenated blood around. There may be heart murmurs, as we had in the patient in the last lecture with aortic stenosis. Sometimes on physical exam, you will hear a loud extra heart sound that says the ventricle's really hurting. The patient's breathing fast. You may hear actually sounds from fluid in the lungs and so forth. There's a whole variety of physical findings that the doctor finds that confirms the diagnosis of heart failure. Remember from the last lecture, the most important thing are the symptoms. They give you the clue 90% of the answer of the diagnosis is in the history. You then move to the physical exam. Oh, yes, I'm hearing things, I'm seeing things that suggest that the reason the patient is tired, the reason the patient is short of breath, the reason the patient has swelling in their legs is because of heart failure. Right ventricular heart failure alone can cause a different set of symptoms and signs. Of course, the edema, the extra fluid, is in the legs. And you will remember that you may have problems in the abdomen because the increased venous pressure backing up is not only in the legs, but it's also in the abdomen. The liver swells. So there's also swelling in fluid in the abdomen. Patients may find their waist size gaining. They become very, very tired. And often you can even feel on physical exam this bulging abdomen that's full of fluid. Remember, again, right heart failure, much less common than left heart failure. Commonest cause of left heart failure, ischemic heart disease, that is, previous heart attacks. So here's a few diagrams that just show you what the cardiologist sees when they see a patient, usually with very clear and significant heart failure. And you can see their pupils may be dilated from the adrenaline that's circulating. The skin may be gray or pale or even blue, cyanotic, and a whole bunch of things. They may be short of breath, breathing fast. They may be uncomfortable lying back and feel more comfortable breathing sitting up. There may actually be sounds in the lungs from fluid in the lungs, crackles or so-called rowels. They may have a cough from the excess fluid that's in their system. There is often increased pressure in the veins, and you can actually see that in the neck. I'm going to show you a picture of that. And the blood pressure may be decreased because the cardiac output is down. And also the patient may even have some discomfort in the abdomen, swelling and nausea and so forth. And of course, you may see bulging of the abdomen, as I mentioned, and edema that is swelling in the legs. All of these are not seen necessarily in one patient, but in individuals, you may see a number of these findings. And of course, patients' anxiety level is increased. Of course, because they're short of breath. One of the worst things that can happen to you is to be suffocated. It activates anxiety in a huge way. And again, you may see the fact that the patient has decreased oxygen saturation. Often we can test that with a little finger thing or an ear thing to see that the oxygen level in the blood is going down. The patients in advanced heart failure may be confused, particularly in elderly patients. There may be, as I'm going to show you a picture in a moment, the jugular vein is distended because of high filling pressures in the right atrium transmitted back to the jugular vein. There can, if the patient's had a heart attack, there may be chest discomfort in association with this. Of course, the patient is markedly fatigued, and you may hear the heart sounds that I mentioned before, this extra heart sound. The heart may be increased in rate. And again, you may feel swelling of the liver or the spleen from the venous congestion that goes back there. And of course, there's decreased cardiac output if you measure that, often with an echo. And the pulse may be therefore weak. The patient is often cool. The skin may be sweaty. So here's a picture. This is a lovely picture of a distended internal jugular vein. You can see it rising up from just above the clavicle, the bone that's right here on the front of the chest, and you can see rising up almost to the level of the jaw. So this is a patient with quite advanced heart failure. In this case, it's a finding of right ventricular failure, but the commonest cause of right ventricular failure is often left ventricular failure that increases pressure in the lungs, increases the work of the right ventricle, which eventually fails. So this could be a patient with left ventricular and right ventricular failure, or it could be somebody with isolated right ventricular failure. And here we see an example of peripheral edema. You can see you push into the soft tissue of the leg, and you'll notice that the impression stays when you take your finger away. So this is a patient with advanced peripheral edema. It also looks to me like the skin doesn't have its normal tone, its normal color. It looks gray and mottled, and often this is because of decreased cardiac output. So, of course, we're going to do some tests to confirm our clinical impression. We've had the history. Oh, this suggests heart failure. The patient's short of breath. They have peripheral edema. Oh, we listen to the heart and we hear an extra sound, the S3 gallop. Okay, we now pretty sure the patient has heart failure. Then we do a chest x-ray. You can see the two examples here. The one on the one side is normal and the one on the other side shows an enlarged heart. Sometimes we will even see evidence of fluid in the lungs. Pretty obvious on this chest x-ray. This is called pulmonary edema. The left ventricle has failed significantly, and what we see is fluid throughout the lungs. And of course, this patient is very short of breath. They might be breathing at 30 or 40 times a minute. Normal is about 12, 13, 14 times a minute. And you may actually hear gurgling from this fluid that's collecting in the small alveolar sacs in the lung and being transmitted into the bigger bronchial tubes. This can drop the oxygen saturation in the blood, can lead to fatal arrhythmias, and people can die from this. And this is a medical emergency that requires urgent therapy. And here is a chest x-ray showing a variety of findings of a little less serious heart failure. One can see edema in the lymphatics, so-called curly lines. One can see fluid collecting in the pleura. You can see in the little angle there where the heart meets the chest that there's a little sort of rounded area. That's actually fluid in the pleural space, the space that surrounds the lungs. There's a variety of other findings that the radiologist will often call you up and say, your patient has heart failure. We often do an echocardiogram to see how bad the heart failure is. For example, is it left ventricular? Is it right ventricular? Is it very advanced? Is the ejection fraction, that is the percentage of blood squeezed out by the heart, very low? Or is it only modestly reduced? This is an echocardiogram from a patient with very advanced heart failure. The left ventricle is markedly dilated. We don't see the film with it, but I'm sure if we saw the film, instead of the ventricle squeezing normally like this, it's doing this. Hardly squeezing at all. And you can see also in this echo, the left ventricle is enlarged. So this is a patient with long-standing heart failure. So let's talk a little bit about treatment. Clearly, treatment goals are to reduce the edema, to reduce the excess fluid volume, and to make the patient much more comfortable and able to have full activity. You'd also like to increase the pumping ability of the heart. Sometimes, if it's, for example, in the patient we talked about in the last lecture, somebody with aortic stenosis, taking away the stenotic valve and putting in a good valve allows the ventricle to recover. In other settings, if it's due to severe ischemia, lack of blood flow in the heart, coronary bypass or angioplasty may improve the blood flow in the heart and may, not always, but may improve the function of the ventricle and again lead to resolution of symptoms. And there's a variety of drugs that help increase the removal of fluid from the body. For example, diuretics that increase renal excretion of water and salt will reduce the excess volume of salt and water in the body and often lead to marked improvement in the symptoms. Patients with heart failure, particularly new heart failure, require hospitalization. They require a number of tests to determine why they're in heart failure. And they also require a number of drugs that are used to improve, if possible, the function of the heart and to decrease the work of the heart and to increase fluid and salt excretion. And what you do, this step diagram is a complicated one. I'm not anticipating that anybody needs to learn this right away, but it shows you as the heart failure increases, the aggressiveness of our therapy increases. So in the beginning, we use ACE inhibitors. That is, they vasodilate the arterioles, they decrease the blood pressure a bit, and they decrease the work of the heart. In a sense, what we're trying to do is rest the heart, make the heart's job, the left ventricle's job, a little easier. But as you go along, there's a variety of other interventions that are used, both improving blood flow, for example, with angioplasty. We also use drugs that rest the heart a little bit by decreasing the heart rate, beta blockers. And then eventually you may even progress to devices that increase the pumping ability of the heart while you're getting ready to do something more aggressive, for example, change a heart valve, or even in the most severe stages, do a heart transplant, give the patient a new heart. It's important that patients have lifestyle changes, particularly with the milder forms of heart failure, because what we're trying to do is prevent heart failure from progressing. So what are those lifestyle changes? Clearly, somebody who's obese, you've got a lot of extra weight around. If you have a big belly that has 40 or 50 pounds of extra weight, it's like you're carrying a 40 or 50 pound knapsack on your back and you're asking the heart to do that extra work. You can imagine that's a bad idea. So dieting and reduction of obesity is important. Number 2, cutting back on salt, because the more salt you take in, the compensatory mechanisms of the body hold on to that salt and, of course, increase blood volume. So restriction of salt. It turns out that regular, particularly in the beginning, supervised exercise or physical activity actually improve the whole cardiovascular system and enable patients to do more work with the same cardiac output that they had before. And of course, stopping things like cigarette smoking, which are damaging to the blood vessels and which can cause acceleration of atherosclerosis, just as we talked about in patients with a heart attack or coronary artery disease. There's a whole variety of lifestyle changes, and often these are integrated between the cardiologist and a good cardiac rehabilitation program. And then there's a number of medications. I talked about them briefly before. Let me describe them in just a little more detail. We give beta blockers. Beta blockers block the effect of adrenaline on the heart, and they decrease the heart rate. No surprise. You got a sick, tired heart. You don't want to keep it having a high heart rate. You want to decrease the heart rate. And actually, sometimes the ventricle recovers when we get the heart rate, which had been 90, down into the 60s or 70s. 2, we can give ACE inhibitors. That's the angiotensin converting enzyme inhibitors. What these do is they block the renin-angiotensin system. They decrease the constriction of blood vessels in the periphery, drop the blood pressure a bit. They also increase sodium and water excretion. So you can see, A, they help by decreasing the work of the left ventricle a bit, and B, they help get rid of some of the excess salt and water. Diuretics, I already mentioned, they increase urine flow and consequently increase sodium and water excretion by the heart. Of course, you can see that there are also possibilities of increasing the squeeze of the heart. It turns out that increasing the squeeze of the heart can sometimes overtax an already tired heart, but at least one agent, digitalis, seems to be safe. In critical situations where the patient is in shock, that is, they have a dangerously low blood pressure, we give intravenous drugs, for example, intravenous adrenaline-like drugs that increase the contractility of the heart, but you can only do that for a short time because, in a sense, you're whipping a tired horse. So maybe it runs a little faster for a short time, but it dies sooner. So we're very careful with the use of drugs that markedly increase the contraction of the heart in heart failure. And again, here you see all the drugs listed that can be used. You can see the beta blockers, the ACE inhibitors, the diuretics, and then the inotropic agents on the far right are the ones we try to use as little as possible. And again, there's patient counseling. We already talked about the lifestyle. Alcohol is a depressant on the heart, so we want patients drinking as little as possible. Smoking has to stop. We want weight control. We want regular exercise. All of the lifestyle things, again, repeated to work with the medicines that we're giving or to work with the interventions, for example, opening up a coronary artery or replacing a heart valve. And further patient counseling, of course, involves the medications. Are the patients taking the medications, and are they taking them regularly and as appropriately prescribed? This is a huge problem. In the United States, many patients fail to take their medications. If there are surgical or catheter interventions, what these contain and what they can do and what the potential complications are. One wants to reduce stress in the patient's life. One wants the patient to keep track of symptoms. Are they getting better? Are they getting worse? Is their weight gaining all of a sudden because of a marked increase in fluid retention? And of course, we would like patients to not overindulge in fluid intake, and certainly come for follow-up visits with the doctor or the nurse clinician in order for us to monitor how things are going with therapy and if we have to make further adjustments in therapy. So, in conclusion, heart failure is a growth industry, particularly in older individuals. It's caused by many diseases, but in particular by atherosclerotic heart disease that causes damage to the left ventricle. Again, left ventricular systolic heart failure is the commonest. The left ventricle doesn't squeeze as well, and the commonest cause of that, ischemic heart disease. Prevention, of course, is better than cure. I don't have to tell you that. And how do we prevent that? By controlling atherosclerotic risk factors before they put the patient in the heart failure situation. Of course, there's a whole variety of diagnostic tests that we use when the patient presents with heart failure. But remember, the clue is in the patient's symptoms with confirmation by the exam, and then we do some sophisticated tests to see what's the cause of the heart failure and how severe is the ventricular damage. And then we introduce a whole variety of therapies, both drugs and even some of the newer device therapies. For example, we can open up blood vessels, and even in extreme cases, we can take over with little pumps for the heart while we're trying to get it to respond and come back to normal. And of course, then we're going to have to do lifestyle changes. There's a new pacing protocol with a special pacemaker that can, in some selected patients, can improve the pumping of the heart. All of these are fairly extreme things done right at the end. And again, we talked about the fact that there's a lot of technology here, but the best deal is to stop the heart failure before it starts with reduction in risk factors, or identifying it early and getting all of those things, including the lifestyle changes, implemented before the patient progresses to a point that they need things like biventricular pacing and heart-lung machines and so forth. Thank you for listening to this lecture. I look forward to seeing you with the next one.